Hi everyone, welcome to researchmd.com. We're going to teach you everything about the pathogenesis of DKA. So a great presentation, so let's start. So let me ask you this, what is the definition for DKA? Somebody tell me. What's the definition? Come on.
Glucose levels in
Yeah.
the blood maybe less than 300.
250. So
Okay.
some number you have to know. I mean, blood glucose greater than 250. Okay? And then what is the other thing?
pH
pH. What's the number? Magic number for the pH?
less than 7.6.
7.25.
Okay.
Acidotic, right?
Yeah.
pH is like less than 7.25. What is the other thing? Bicarbonate.
Bicarbonate.
What is the magic number for that?
Less than 15.
15. So 3 numbers you have to know. Like a lot of times, people interview, come for interviews and all that. And the first question I always ask, tell me the definition of DKA. Majority of them don't know the definition of DKA. So now let's look into the pathogenesis. That's our whole purpose. So we have this nice schematic diagram over here, kind of explaining as to what happens. Okay. So where does insulin produced?
Beta cells.
Beta cells. Very good. I think everybody know that.
Right.
What kind of hormone is like insulin?
Polypeptide hormone.
It's a polypeptide hormone. Okay, so insulin that helps in the entry of glucose into the cells, right? So in normal mechanism, we had it on the left side. So insulin act on the liver, cross like glycogenesis for future storage, and then decrease the gluconeogenesis, right? So what happened in the skeletal muscle? It also increases glycogenesis, formation of glycogen, and increased protein synthesis. Okay, so the next thing is they act on the adipose tissue. What does it? Increase adipogenesis, increase fat storage right here. Okay, and then decrease the lipolysis, and there's no reason for energy to come from lipids over here. So remember, so increase glycogenesis in the liver, increase glycogenesis in the skeletal muscle, and increase adipogenesis in the fat tissue. Okay, that's the main role of insulin. We know it's like a summary, it's a polypeptide hormone. So what happened in the DKA, right? So in DKA, I mean, let's talk about DKA, right? Which one, type 1 or type 2, like which one is this common?
Type 2.
I would say more common if you have to say like type 1, I mean type 1 DKA is more common. Type 2 is also becoming like more common. So what is the mechanism is kind of difference between type 1 and type 2? We say like, type 1, there's like usually like no insulin at all, right? Type 2 is more like what?
Insulin resistance.
Insulin resistance kind of
Right.
more kind of things and all that. So what happens if you don't have insulin, right? That is the main thing. When you don't have insulin, then you have all this counter-regulatory hormones. Somebody tell me the name of the counter-regulatory hormones?
Cortisol.
Cortisol,
Yeah. Glucagon.
growth hormone, and catecholamines.
Right.
Okay,
Right.
they have their effect on all that. So when you don't have insulin, there is decreased utilization of glucose, right? So glucose is going to be bled, and then what's going to happen? Hyperglycemia. That's like very common, right? Because glucose cannot get entered into the cell, they stay in the blood system, they're hyperglycemia, high blood sugar. So next thing what happened, there's also proteolysis, okay? And proteolysis, there's going to be decreased protein synthesis that also contribute to gluconeogenesis. So what happened to our blood sugar? Goes up, there's hyperglycemia. And then what is the other major mechanism? There is glycogenolysis, right? And then glycogen breakdown, and then what happened? Hyperglycemia, right? The main thing. So what happened to our blood sugar? Like in our definition, what is the number one definition is blood sugar greater than 250, right? Now let's look at the other major mechanism. There is always, there's going to be increased lipolysis. Now fat is breaking down for like energy, right? Then free fatty acid in the liver that are converted into ketosis. Then you got ketoacidosis, and then you got lactic acidosis. Okay, so tell me the the type of ketones in the blood. When you check, what will you find? What are the ketones? Main ketones. Name.
Acetone.
Yeah, acetone. You can say acetoacetic acid that kind of converted into acetone. What is the other one? Beta hydroxybutyrate. So which one we usually check when you have like a diabetic DKA patient? What is the first one usually we check? Which one?
Acetone.
Acetone or like a beta hydroxybutyrate?
Acetone.
Wrong. Always check because acetone comes into the blood and kind of goes through plasma and all that really fast, and body try to get rid of fast. You may
Okay.
not be able to measure that. So always kind of measure the beta hydroxybutyrate, okay? And then always there is like lactic acidosis, and then what is the main component? There's anion gap metabolic acidosis, right? That is the main component. That's why we're treating the patient. That's where all the complications comes in. Because when you have acidosis, arrhythmia, and all the things come into here. What happens when you have high blood glucose? You got glucose in the blood. I mean, it goes into the urine, glucosuria, and what happened? Osmotic diuresis, right? When you have it can attract the water, and glucose goes with the water, going to the urine, glycosuria, right? Then you can have like dehydration. When you have loss, then you have like a polydipsia, okay? All of this kind of things happen. Okay, now let's look at, I think when we talk about the main mechanism complications, one is anion gap metabolic acidosis. We already talked about the mechanism, what happened to anion gap metabolic acidosis, right? The number two mechanism, look at what happens hyperkalemia. Number one, I think you need to know, you have lactic acid or all this acid, right? That causes like increased acid in the blood. So what happened? This increased acid kind of H plus K plus mechanism kind of affected. So you got the H plus acid come into the cells, more acidotic, right? And the K plus going in, so you kind of lose the potassium, right? Not like becomes hyperkalemia, right? So become acidotic, acid enter the cell, and potassium come to the blood, okay? And then what happens also? What is like insulin, like there's no mechanism of insulin is all usually kind of help with the potassium, sodium potassium ATPase pump, right? So what happens? Insulin, the normal insulin go from potassium is going to enter more in the cells, and the sodium come back up. So this is kind of effect, so you're going to have like more potassium. There's like now, that's the mechanism for hyperkalemia we need to know. Right? The other one is like hyponatremia. What's the mechanism of hyponatremia? It's very common when somebody comes in, right? Mainly this is like a dilutional hyponatremia. What happens is like you got glucose in the blood, you got like osmolarity goes up, and then what happened? It also just kind of draws water, making it the osmolarity, and you got osmotic diuresis and all that can happen. And that is what you can have the hyponatremia. Remember, it's like more like a dilutional hyponatremia. The other thing it could happen is like osmolar gap. That also could be increased. Okay. Mainly the contribution for osmolar, I think you need to know the formula. It's very important. Not only in DKA, a lot of other conditions like alcohol poisoning and all that. What is the formula? You take 2 times sodium plus glucose divided by 18, BUN divided by 2.8 plus ethanol divided by 3.7. Okay. It's very important. A lot of, if you a lot of textbook and online thing does not mention about the ethanol, which will make another presentation soon. So the main reason for osmolar gap, so how do you measure the osmolar, calculate? How do you calculate? Somebody tell me, people always make this mistake. When I ask about osmolar gap, how do the people usually do?
It's the serum osmolarity.
Okay, you have to do one measure. You put an order in there to measure serum osmolarity, and then you calculate the serum osmolarity by hand using the formula, and you see the difference. What is the normal osmolar gap? What is that?
Less than 10.
Yeah, I would say like 10 to 12, just like an anion gap, right? In that, because of reason you need to know the formula, because of this ketones, those are the one pretty much causing the high, the high osmolar gap in this patient. It could be elevated. So the major thing we need to understand is about anion gap metabolic acidosis, there's going to be hyperkalemia, there's going to be hyponatremia, and there's going to be osmolar gap. Okay? All right. Thank you so much. Take care.